Also wanted to acknowledge that in today's presentation, you'll be seeing materials that are copyrighted by Ariadne Labs, as I mentioned earlier, Brigham and Women's Hospitals, and the Harvard T-Chan School of Public Health, as well as Dana-Farber Cancer Institute. These particular slides will probably be featured much more extensively in the presentation that I mentioned to you in mid-December that Dr. Karen Porter-Williamson will be going through. She'll be actually talking about the curriculum that she went through, a 2.5-day curriculum that she went through in Boston earlier this year on serious illness care programming for clinicians. And that will really be targeted primarily to physicians and advanced practice nurses, as well as the people in the acute care setting, other team members in the acute care setting that may be on palliative care services. And so I just wanted to make sure that you were aware of that. A quick review of the objectives today is to hopefully understand the functional trajectories of patients with advanced illness in the months and possibly even a few years prior to death, so that we get a better picture of that. Incorporate serious illness care planning into the provider workflows. Again, as I mentioned, that'll be more extensive in the third session that we're doing, but we'll get a kind of an overview of today and why that's important, especially in tertiary environments. Recognizing the benefit of using serious illness conversation tools to guide those conversations, basically reinforcing that the goals of care and the importance of families and their values and their preferences need to be incorporated into the clinical discussions we're having as advanced illness progresses or comorbidities occur during the course of an extended life and progressive disease. We'll also do some differentiation between the legal and ethical distinctions in advanced care planning and talk a little bit about fiduciary duties and the limits on powers of attorney, especially within the states of Kansas and Missouri. And then finally, clarifying advanced care planning processes as distinct from the documentation process. That this is really about engaging families, engaging patients in the discussions that they have about their values and preferences and what kind of lives they want to lead, what kind of their own ability to differentiate the burden and benefit of care as they progress through the final chapters of their life. And then finally, translating goals and values and preferences into transportable medical order sets that actually, as we call it, TPOP. And then, as I mentioned earlier, the November 30th sessions will go into that more completely in an hour-long session. With that, I'm going to turn it over to Susan and let her walk us through the first case study that we are going to help kick off the training session today.
Thank you, John. I would like to go over with you a story that's very, very familiar to many of us that will get us started this morning to really think about what we're going to deal with as we deal with the advanced care planning. This is Roy's story. Roy is a 71-year-old with severe COPD and mild dementia. He was in a SNF after a recent hospital stay for pneumonia. He's now having increased shortness of air and mental status changes. So EMS was called when the resident was not responding and the respirations were 8 per minute. His O2 sats were 79%. In a recent conversation with the staff, Roy expressed, "I don't want to be kept alive by machines. I want to die in peace." EMS applies oxygen and transports Roy to the ER. In the emergency room, Roy is unresponsive. He's hypoxic despite the oxygen that he's receiving. His chest x-rays show large lung volumes without consolidation. His arterial blood gases show marked respiratory acidosis. He's then intubated and transferred to the ICU. The family then is contacted. They make plans to come to the hospital, and over the next few days, Roy becomes more responsive but still very confused. He's agitated and restless. The daughter's very distressed because the father's wishes were not followed, and the decision is made to sign a DNR order and to extubate Roy. After the ET tube is removed, Roy gets calm. Plans are made to transfer Roy back to the SNF, and after 2 days at the SNF, Roy dies. Is this a familiar story? It goes on and on every day in many of our long-term care scenarios across the country, but definitely in the 2 states. So the gap between what the patient wants and what the patient gets. Patients with serious illness have priorities besides living longer. They would like symptom management and quality of life. They want a sense of control and completion, and they want strengthening relationships. They want to be sure that they get their affairs in order before they leave this earth. But most people want to be at home and prefer comfort-focused care at the end of life, but that is often not the reality. 86% of Medicare beneficiaries want to spend their final days at home. 25 to 39% actually die in an acute care hospital, and 70% are hospitalized in the last 90 days. 29% receive intensive care in the last 30 days, and many experience care transitions and very short hospice stays. In fact, the latest information from NHPRO shows that about 35.5% of hospice resident patients die or are discharged within 7 days of admission. So that's a very, very short hospice stay for our hospice patients. What patients get often harms them and their families. They're getting aggressive care for patients with advanced illness, and it's often harmful. For patients, it's a lower quality of life, greater physical and psychological distress, and for the caregivers, there's major depression and lower satisfaction. There's just not enough time to work through these issues, both for the patient and the family, when you've got a 7-day length of stay in a hospice situation.
So let me interrupt there, and this is normally when if we were face-to-face with you, we'd have some conversations and try to get some feedback from you all. So if you have comments and you'd like to submit them, please do. I think what Susan and I have really tried to bring forward in this segment is trying to humanize this experience, and we all appreciate it and understand it in terms of the services that we need to provide in a clinical environment, but we haven't taken the full benefit of being able to sit down with families and really try to determine how it is that the care plans should actually go once they hit the acute care environment. That we really, when we transition from one care setting to another, it usually escalates in terms of the default systems that we offer. We assume that people want to be able to have aggressive care when they activate the emergency system. That's just a common experience and a common understanding in terms of, well, why do you call 911 if you didn't want us to do something? And yet at the same time, many of those situations are such that the patient is really very vulnerable, very fragile, and has fallen and really has a need of basically being able to be stabilized or being some intervention in terms of a medication or treatment related to pain. Maybe it's nausea, maybe it's any kind of symptom that needs to be controlled, but we're not very good at kind of deciding at the point along the way that we need to stop with the aggressive rescue medicine, kind of shifting from rescue medicine and over to palliative care, and really what needs to be focused on in terms of their care planning and goals of care that are more consistent with what it is that they have identified or maybe not identified. And so part of our I guess, goal here and the importance of being able to make sure that we're doing a better job of this is to encourage you as facilitators and champions within your own organizations and in your roles as social workers or nurses in long-term care settings, or as advocates for families, as chaplains and other healthcare professionals, to really begin to take a look at quality of life, then the goals around independence, the goals around how it is that families really express their values and preferences in terms of their treatment, so that we can really incorporate Roy's situation more proactively rather than waiting until a bad episode occurs, an emergent event happens, and we activate the emergency system and really are not very responsive to the needs of the patient going forward. So I would like to be able to engage you guys in some conversation around this, but when we did this session a couple of weeks ago with a group of about a dozen or so folks in mid-Missouri, we really had some very robust discussions about, the nodding of the heads. It wasn't just nodding of the heads. It was that, these are the kind of things that end up harming patients, and then sometimes they never see them again, even though they may have sworn to the patient that they're going to stay there until their final days, and they've been in the nursing home for 7 to 10 years. And they're really trying to make sure that the services and the support systems and the and the extended family for many of those patients are really able to provide the care and support that they need in a non-acute environment, because there's very little benefit that can be achieved for some of those people if they do hit the acute care setting. Susan, you have anything you want to add to that?
I just want to add that really these are very hard conversations to have, and patients and their families are very willing to talk about it. 60 to 70% of people affirm that speaking with their doctor or family about their wishes is important, but actually only 15 to 20% do that. They indicate they're waiting for the provider to bring it up. They don't want to talk about it too early, and they're really struggling with getting the right information, accurate information in a timely manner that helps them and their families deal with the journey that lays ahead of them.
Yeah, and I have a really personal example of that in terms of not wanting to bring it up before, it's too early. My mom cared for my dad for 26 years at home, half their married life, and he was a stroke patient. And during the final stages of his illness, he was actually in hospice, as Susan mentioned, only about 4 days. Most of those 4 days were in an acute care setting, mainly because mom was doing such a great job of caring for him in a home care setting. None of us really realized how advanced dad's illness had become. He was not very oriented to time and place and couldn't communicate very well, but was still able to respond to questions and answers that we were posing to him. But and here I am, a veteran hospice professional, many years experience, not realizing that he was as sick as he was, and that the burden of care for her was becoming more and more extensive. And we really never even had the discussion in the home care setting until dad ended up in the hospital on an episode based on the fact that he had a wound that wasn't going to heal. And mom had done a terrific job of caring for it, but it was open to the bone and causing extreme amounts of pain, which dad wasn't really very clearly able to express. So, I don't want to portray this as something that's a failure of the medical system. I felt like mom was doing a fabulous job of caring for him. And we were, I'm a veteran hospice professional and should have, we thought had a little bit better angle on what was going on here. So I think a lot of this is this fear that we have in American society about talking about death. And if we can engage people in these conversations, and noting the statistics here, is that a good portion of them, especially those that are dealing with fragile health to begin with, are ready. They want to be able to talk about what's going to happen, even if it's in the theoretical kind of esoteric sense about, well, what does this look like as it progresses, and how do we begin this conversation, and what are your hopes and dreams about being able to spend the next chapters, the next few months, whatever it is that remains, and being able to elicit some of those goals and values. And that's what we're going to be hopefully talking about today, that are absolutely integral to understanding what the clinical steps are that we take then when an episode actually occurs. Susan, you want to continue?
Yes, the conversations that we are having are too little, too late, and not great. There are multiple studies that show patients with serious medical illnesses do not discuss end-of-life preferences, or they first discuss them only in the last days to a month of life. So, interestingly enough, among these are patients with advanced cancer. The first end-of-life discussion occurred, the median, in 33 days before death. Median means that half the people it was later than 33 days, and half the people it was less than 33 days. So 55% of that initial end-of-life discussion occurred in the hospital, and only 25% of these discussions were conducted by the patient's oncologist. So as the industry has looked at this, what we're really thinking is, speaking of end of life is very difficult for clinicians. And therefore, John, you want to put the next slide up? We are really in the intent and needing to rename and reframe this end of life discussion. And if we can get away from the idea from a clinical point of view that this patient is going to die pretty soon, and not wanting to admit that, then the conversations are about a person's priorities for how they want to live. These conversations are intended to help someone prepare over a course of months, even a year or two. So this is not about people at the end of life. It is about people living with serious illness. And I think all of us in the clinical world understand what a serious illness looks like. Our hesitancy is trying to estimate or determine or give them the notice that it may be end of life. So we're going to rename and reframe this whole approach to discussions as a serious illness discussion and not end of life discussion.
So with that, you're going to see very little information that we're going to be putting out from this point going forward that really refers to these discussions as end of life discussions. We're going to try to eradicate that from our language. This has been reinforced by the 2014 end of life study by the IOM, that the reference and the term end of life does not resonate with people. In fact, they actually reject it, and they are cautious about it, and it actually impedes discussions with clinical providers. So if in your setting it's still being referenced as end of life discussions or being referred to as end of life care, we are really proposing that you consider changing that language internally within your own institutions, both in the long-term care setting and in the acute care setting, and talk about serious illness, because everybody understands what that is. It can occur at whatever point in time that there's an episode, if it's one time and out, or whether it's a recurring situation that goes progressively worse. And in most situations that we're facing, that will be true. So, because about 85% of us now, given the trajectories of illness since the mid-2000s, early 2000s, we now know that 85% of us will probably die of a chronic disease or a chronic condition as opposed to any kind of acute care episode. So the reframing and renaming is very important, not only for the home, the community setting, the home setting, outside the hospital, but also for us to begin to reframe and rename that conversation within our institutions and in long-term care, so that we can really begin to focus on the goals of care of the patient, what it is that they consider to be of importance to them in their treatment and care planning. So this is another kind of reinforcement in terms of how we would talk about this. This is again coming from Ariadne Labs. Karen will probably go into this again in her session in mid-December, far more in depth. It's a very busy slide, and I'm sure she'll take some time to walk you through it, but we did want to at least prepare you for that session, that we really talk about proxies and healthcare planning in general, kind of at what we consider here at the center, kind of a wellness frame in the early days. So any healthy adult should already be engaged in conversations about theoretical care preferences, not necessarily specific, but theoretical care preferences, and should be naming an agent. All of us should be naming an agent. The most serious cases that the United States has ever faced, the three that made it to either state or Supreme Court levels, were all young women in the ages of in the early 20s. And so it's very, very clear that young people in general should at least name an agent. But the question then becomes, so I name an agent. Well, what do I tell that agent? What kind of conversation do I have with them? And that's really where the values and preferences come in, not specific treatment objectives. We don't want to go through a checklist, a laundry list of I want this and I don't want this. We need to talk about what important values we have associated with the sacredness of life. What does family mean? What kind of benefit and joy do I get from knowing my family and sharing things with them, and those kind of things. So it's really around values and preferences at that point, and really further on as well. As you'll notice in the second box then, the diagnosis of serious and chronic illness that occurs is the first step where we begin to take a look at having more goals of care type of discussion. So in the first session, it's planning in that lighter color. It's planning in advance for serious illness and that kind of thing, and then serious illness conversations actually change in context as the progression of the disease. So you get down finally more into actual treatment plans and goals of care related to those treatment plans as you progress. Asking families and patients to jump to the right hand of this screen early on in terms of initial conversations is premature, and it doesn't work, and that's why people don't complete living wills and they don't complete healthcare directives. They may name an agent, and then they're kind of lost in terms of how they have the conversation with the patient and family. There are tools and resources that we can help with on the left side of this, and that's really where most of us in our institutional environments can participate in National Healthcare Decisions Day. promoting advanced care planning, getting people to talk about what's important to them, especially around the importance of naming an agent, somebody who will speak for them, understands who they are, and how they will make decisions for them when we can no longer make decisions for ourselves. Moving on to the right part of the screen, then after that serious illness has been identified, again, the complexity and the depth and the content of the discussions changes because the context of the illness and the clinical progression changes. And that's a very different kind of conversation. And as I mentioned earlier, Karin will be doing much more of that in depth, but we just want to kind of to give you a picture of kind of the progression of this disease. So this is a much more subtle and nuanced presentation of how advanced care planning should be taking place. And it really is premature at some point for us to assume that patients can really talk about end of life and poor prognosis and whether or not they'd want a feeding tube or not. I mean, theoretically, most of us probably would say, it's very unlikely that I would. But as we get further down in that spectrum, we find that people don't necessarily change their values. They just change their understanding of what it is that's being presented to them. So there's been a lot of social science research done on this. And the portrayal of it has been, we used to think about it as kind of the moving goalpost syndrome, that people changed as they moved from the left to the right of this screen, because things that they thought as being unacceptable or intolerable at the age of 35 or 40, all of a sudden become very acceptable at 50 or 60 or 70 when they're diagnosed with a condition. And what the social science research is showing us is that they don't necessarily change their value. Independence is still very important to them. Their decisions around values, about their sacredness of life, are still very important to them. What changes is not the goalpost and where it stands in terms of the post, but how wide and narrow the uprights get in terms of that same metaphor. So what we're encouraging people to do is to say, at the very left hand of this screen, you can position those uprights wherever you want, because what's most important for you is to put that post in the ground and say what's important to you. Don't worry about where the uprights are. Don't worry about how far apart or narrow they are. That will happen over time for most of us, because we will have time to spend with our clinicians and our care providers in determining how wide or narrow those uprights get. But what I want to make sure that you're hearing from me is that the goalpost is still pretty stable. We can really rely on the values of people, really the fundamental core values really remaining pretty firm during the course of their care. So as you're talking to families or they feel like something's premature, I think if the football metaphor works, use it to talk about how it's important for us to establish the goalpost and know that you're in the game, that you've got your agent next to you, and you can talk about those things that are important, and don't worry about how far apart or narrow the uprights are. So when it's time to start, when is it time to start serious illness care planning? For most of us, the surprise question is really kind of what's connected, obviously, to the Pulse initiative as well. So if you ask the surprise question, it can actually help. And there's good evidence now in the literature that the surprise question really does work. We're not very good at the hospice question, the 6 months or less, but doctors are pretty good about answering the question of the surprise question. Would it surprise me as the clinician if this person were to die in the next year? If the answer to that question is no, then it's very likely time to begin the conversation with the family. So it's not necessarily the family who needs to come forward and say it's time to have this conversation. We welcome that, obviously, but it really is at our initiative to answer this question first. Would it surprise me if this patient were to die? Not were the patient alive. We need to make sure that that's been kind of portrayed in the literature in reverse states as being the same question, and it is not. Would it surprise me if this person were to die in the next year? If the answer to that is no, I would not be surprised. Then beginning the conversation around serious illness in terms of the kinds of care, the kinds of treatment, and how their personal goals and preferences fit into that is really time for us to begin. So for cancer and renal patients, the surprise question does a better job of predicting mortality than even the current hospice Medicare certification criteria. So that's, again, true for those that have progressive disease. So this really is a a better question really to ask. This doesn't mean they're ready for hospice. It doesn't mean they're ready to have a conversation about accepting palliative care only in terms of their care plan. It just means we need to get a clear picture of where this patient is in terms of their own thinking and their agents and loved ones and representatives, moral agents that they surround themselves with, in understanding what kind of support and what kind of treatment they're thinking is going to be important for them as they move forward. And recognizing that functional trajectory can really help. So being able to talk about how it is that we're not where we were 3 months ago, we're not where we were a year ago, or mom's been in the hospital 4 times in the last year. What do you think that means? Asking open-ended questions, involving the family in being able to articulate how they see the progression of the disease and the functional trajectory, and then putting some framework, confirmation, explanation around that. These are not, as Susan's mentioned, they're not easy discussions to have, and they're time consuming, but that's part of why Medicare has begun to say we can pay for these services, and those of you that are engaged in these kinds of discussions can actually begin to spend some time with the families and being able to do it. The half-hour and full-hour segments that Medicare and many now commercial insurance companies are praying for. So Susan, I'm going to let you go through the functional trajectories and talk a little bit about kind of your work that you've done with families in the situation in long-term care.
For those people who have a non-cancer illness trajectory or diagnosis, we really see this slow decline, then there's a periodic crisis, and then they come back, but they don't come back quite to where they were before. And then they have another decline, further decline, more serious, more crisis, and then ultimately ending in a death. This really is pretty classic of what we see, particularly in long-term care in the skilled units. The person was as good as they get, even 1 to 2 days before the event, which may cause them to die. So the family holds on to, he or she's been through this before, they've always come back, and therefore we're just not prepared for this death that is happening, or it does happen. So it's shocking to the family. Even the doctors can't see the death coming up. This is pretty classic for COPD patients, for congestive heart failure patients. These folks are the ones that end up going to the hospital, as did Roy, and then going to the ICU, and then eventually, unfortunately, passing away in the hospital because their disease has just overwhelmed them. So the Lazarus effect we see is that dad always gets better because he has 6 times, so he'll get better this time. That's that hope that families hold on to, and it isn't always true, and it isn't always going to be true. The other trajectory that we see is the dementia trajectory. These are the residents that linger. We know they're declining. There may be some serious illness, a urinary tract infection, a pneumonia. They're very, very frail, and as they decline, then they ultimately that ends up in their death. So each one of these trajectories we see very, very commonly in long-term care. It's kind of the world that we live in. So
it's also really important for us to understand, and you probably live this every day, most of you, this part of the tail, especially for those that are lingering and they know that there's an expected death that's on the horizon. This right end of the tail can go on in some people's perspective almost interminably, because there is no particular, it may be a completely unrelated event that actually prompts the episode of care that ends up actually taking the life of the patient, a UTI, a pneumonia, or something like that. So this is a very difficult kind of segment of life in order to predict the readiness and willingness and timing for the hospice benefit. So in many cases, these folks may linger for many, many months, and in certain segments of our society actually kind of take umbrage when it comes to suggestions that they might want to seek or elect hospice care, because they're like, mom still, she still has good days, those kind of things, and she's really not, and nobody can tell me for certain where things are. But again, there is an openness, or should be an openness, to having these serious illness care planning conversations about, well, what can we expect? What should we be looking for? What kinds of things can happen? And when those kinds of things can happen, what do we think we might do? So, rather than waiting for the fourth urinary tract infection in the last 6 months that ended up with mom in the hospital, we start talking about the frequency of those kinds of events when there begins to be failing organ systems. And they don't need, the families don't need to get involved in all of the clinical possibilities and those kind of things, but talking about how it is that this patient, theoretically, their life is going to end over this amount of time. And having that conversation about where do you see your mom, and asking those questions in a very open-ended way to engage the family in conversation, or the patient in conversation with their family members, that may bring up, intimate notions and a few tears, and, I wish she would get better, and, I never expected this to kind of go the way it is. Those are all possibilities of being able to explore, and not just with clinicians in the room. Those can be handled through opportunities that the families are kind of brought together and given a few questions and said, we're going to come back tomorrow, sit down with you and talk about this, and would really like for you to kind of have a better picture. And again, there are tools and resources out there. We can make those available to you to kind of help prompt some of those discussions, get people started on those discussions. And obviously for this group, it's very important, if at all possible, to have these serious illness questions clear over here on the left side of the spectrum. So upon diagnosis related to dementia, any kind of serious dementia diagnosis, any kind of serious neurological diseases that really have that very, very long tail on the right side. So ALS, Parkinson's disease, many of those patients and families struggle terrifically with what kind of, they know this is a fatal diagnosis. They're dealing with it early on as a fatal diagnosis, but there's no one there to help them with the conversation about what does it look like then when this tail just seems to go on and on and on. And to make sure that they understand that there's a support system, and that there are people out there that will be able to help them navigate these waters on the right side of the trajectory. I think I probably covered this in my remarks just a minute ago. The gradual weight loss is really the tipping balance in terms of the frailty and dementia trajectory, that the patient is not continuing to maintain weight, continues to lose weight. Those are often very complicated issues in the long-term care setting. Susan, you may want to speak to that in terms of the whole review process and tags and kind of the very regulated environment in long-term care in terms of trying to make sure that a patient maintains their weight and eating and intake and output and all that kind of stuff. So you want to comment on that too?
Well, this is one of those things. CMS has recognized that if the resident is on hospice, that they don't really focus so much on the weight loss. So in my experience, this is one of the things that can get one of these type of residents on hospice, because they're losing weight. There isn't any way for them for the organization to keep their weight up. And so then we begin to think about hospice at that point. But as John said, the discussion related to what the wishes are of the family and the resident, the patient, really need to be very much further upstream way before we get to the point that they're losing weight and need to be on hospice. So.
And if the patient and the family recognize the trajectory and they understand that weight loss will be an integral part of that kind of wind down of the patient's life, then the risk factors associated with the insertion of feeding tubes or an emergent situation in which they end up in the hospital, and in some cases, in one study that was done in Iowa, they found that Medicaid patients who did not have good family support systems, 30% of them ended up on feeding tubes with advanced dementia diseases without anybody within the family system, even though it may have been very extended family, even knowing that that was planned or that it had been prescribed once the patient hit the hospital setting. So if we're going to eliminate or reduce the likelihood that those kinds of things would happen when in fact the families would say, this isn't what mom would want. She told me that, 5 years ago when she was diagnosed. Happened twice in my own family, my wife's family. In both instances, my in-laws were in situations where the question came up about, are we going to insert a feeding tube during the final stages of their life? And the family and the patients had early said, my mother-in-law, who was 91 at the time, had said in her early 70s that she'd never wanted a feeding tube. And she knew, given her sister's progressive disease states, that was a very good possibility in terms of risk factors that they associated with her very likely disease, or her trajectory of illness that she would likely see. And we had early signs in her 70s that she was kind of going down that path. She made it very clear to everybody, including some of her children, who were quite concerned about making sure that we didn't shorten her life, that we didn't do anything that would be untoward in having her die of any kind of hunger, that she wouldn't starve her to death, that we wouldn't keep her from having hydration, any of those kinds of things. And so it was very important for us to have that conversation early on, with her participating in that discussion as much as possible. So again, it's never too early to start the conversation. The depth and the breadth may be different, but getting those people involved in conversations early on is quite important, especially for the family members who are going to be making those decisions, as this slide indicates that dementia is very important because of the incapacity, which may extend for quite some period of time.
John, I might just interject here from the clinical point of view. It is very, very important that when a physician, a nurse, a social worker, one of the providers has this conversation with the patient and or the family, that it get documented. Doesn't have to be on a form. It can be in your regular documentation notes, whether that's nurses' notes or social work notes. But documenting the conversation is very, very important in this whole trajectory of care.
And absolutely critical that it occur not just with the care providers in a clinical setting or in a hospital or nursing home setting, but that occur with family members in as much as a broad way as possible, not just the agent, but other members of the family as well, to make sure that there's a good feeling and understanding among the different folks, because those decision makers might rise up. Other decision makers, who not necessarily named, may raise their hand or raise concerns about the care of the patient when in fact they're not involved in the daily care or in the decision-making process, and raise questions about premature death, withholding of treatment that's basically life-prolonging, and being able to talk about, well, what is burden benefit, and what has mom said about this issue from a long, long time ago. So those are very important considerations. We know that defensive posturing takes place within clinical settings, especially within the acute care setting. And in many cases, decisions will be made about the insertion of feeding tubes earlier than later. And then once they're in, there's a huge barrier in terms of being able to pull the tube if it doesn't achieve the goal that was planned, because of the visceral reaction in terms of withdrawing the feeding tube from patients. Now, there's an abundant evidence of literature now and research, especially for those with advanced dementia, related to the benefit and burden of feeding tubes, and it's quite clear that they do not benefit patients in those final stages of illness. But other diseases, there may be reason for doing it, and there's good clinical evidence in terms of what those diseases are and what they're not. And I would refer you to Dr. Giantino's work at Brown University if you've got questions or would like to look at the literature related to the work that she's done. She's spent the last 30 years doing research in long-term care settings, and I would really encourage you to look at her work in terms of what works and doesn't work in terms of feeding tubes and other types of hydration nutrition interventions for patients in long trajectories that have that wide, long tail on the right side of the trajectory line. So I think wrapping this section up in terms of the trajectories, obviously requiring a system and the provider to recognize the trend and to begin discussions early in appropriate bites and what's consumable early on, and participating with the patient as much as possible, so the clarity around the goals are clear, and that requiring planning from the hospital and the provider's office in the nursing home. I think probably all of you are involved in much more intense discussions with handoffs and transitions in care, and being able to make sure that goals of care are traded back and forth across settings. That's part of the TPOP and PULSed initiative. But at the same time, it's important for us to do that even prior to those discussions. And again, having those discussions that the patients can rely on, the families can rely on, and can be involved in, that are shared, as Susan said, with clinical providers, is important. The support in the community is also very important, and coordinated efforts for preferences to be known across the continuum. And we'll be talking more about that as we get into the work on TPOP.
John, if I might just interject here, the center has some wonderful printed materials related to these trajectories that could be used for discussions with families. Spells out both of those trajectories, and I think it would help a clinician have a nice conversation with a family member. So I just put a plug in for Caring Conversations literature from the center.
Yeah, and those of you that would like to download it, it is available free. It's a 16-page document, and you can also buy them in print form and in bulk. But the document that Susan is talking about is actually a trajectory of 4 trajectories. And it's kind of used as, again, kind of this theoretical discussion that we pose and say, all right, most of us, the first one is the one that kind of goes along fine on the moving to the right, and then it has this kind of horrible episode and death occurs very, very quickly, kind of just to fall off like a big box. And getting people to talk about, well, that was Dad, that's when he had his heart attack back in the 80s and he died and that kind of thing. And I'm thinking that's what would happen to me. Or we have our little stories about, well, I just want to go to sleep and not wake up. And, we don't think about the person in bed next to us who's going to wake up and see us, cold stone dead next to them. And that's not the way, they had anticipated being able to say goodbye to us. So it gets people started on that. And then there's the more progressive disease, which is the neoplasm and cancer diagnosis. And then the 2 that we saw today, which is that jagged kind of edge that just kind of diminishes to the right, and then a long tail. So all 4 of those are presented in that document. And again, we just use it as a tool for people to say, well, let's talk about what we think might happen with us in this situation. And it isn't too early to have those conversations, even for people my age. And when I do presentations and I'm in a group with mostly people my age and older, 60 and above, I'll ask people, how many of you already have the diagnosis that you're probably going to see help you make your exit from this planet? And in many, many cases, I only get 5 or 6 hands. And then I'll say, well, how many of you have a chronic disease that you're currently dealing with? And 80% of the room sticks up their hand. And I'm saying, well, you need to think about this, because in all likelihood, that disease or a condition that accompanies that disease is what's going to be take your life. So it just kind of puts it in more of a theoretical sense that we're proposing that people have that conversation. So I encourage you to use that document if you've got an opportunity to work with your families and patients and loved ones yourselves in terms of kind of theoretically approaching the conversation. And maybe for some of us, not so theoretical, actually engaging in the conversation. So kind of in closing on this section, I want to kind of reiterate that earlier conversations about patients' goals and priorities for those living with serious illness are around enhanced goal concordance, which means that what we're saying we would want actually occurs. So that's what we actually try to measure after the PULSed document or the TPOP document is initiated, that we're trying to say, okay, this is what they said, they expected, and they wanted us to provide to them, and we were able to do that. But it also deals with improved quality of life and reduced suffering, so that we're not putting people through burdensome treatment that they didn't want, didn't expect, never asked for, and trying to honor their wishes and values as they've gone through their course of their illness. Better patient and family coping, because there's kind of, again, this sense of well, this is what we thought was going to happen, or it's more likely that we're seeing what's occurring, kind of what somebody told us to expect, and so it's easy for us to accept that the frailty or debility is progressing, and we need to be thinking about the next steps in that progression process, have a good understanding of what that disease progression looks like, and say, so what's next? Are we going to do a feeding tube? Are we going to treat with an antibiotic? Are we going to, send mom home again and hope that she doesn't get another pneumonia? That kind of stuff. And then finally, higher patient satisfaction during the course of the illness. That even for those that are able to communicate during that progressive disease, sometimes the satisfaction related to basically foregoing a cancer treatment, another round of chemotherapy or radiation or whatever, that allows them to be able to spend more time with family because they feel that we're able to do good symptom management. They're not, sick in bed, suffering from the side effects of those treatments. Usually can increase patient satisfaction, and then obviously helps with the grief and bereavement of the caregivers. And then also a side effect of all of this is reducing costs, but really the reducing cost is basically averting non-beneficial care. That we know that we're wasting resources when we provide services to patients and families that the patient really can't benefit from, and that rescue medicine in most cases really doesn't benefit those people in the long haul because of the serious nature of their illness. Subspecialty medicine can't provide this care to all patients with serious illness, nor should they, and that's why we're calling on all of you, and regardless of your setting, that you're involved in this care. And we just simply don't have enough people with the training, the subspecialty training, to be able to do this. So we need to get scalable interventions, and that's what we're going to be doing in these next series of training programs, is giving you hopefully the resources and tools for you to begin this conversation, so there's greater clarity among the providers, so that when that event does occur, where a palliative care doc comes in or a palliative care consult occurs, or the patient and family welcome that instead of spurning it, may be able to be a very good conversation that then leads to better care for the patients in the future. So the scalability of this is hopefully to get more people online and integrating these kinds of skills and competencies within the skill sets that all of us have as individual clinicians. The guide that we'll be looking at in the future deals with communication skills and training. That this is what Karin will be doing and talking about other studies that demonstrate the impact, and then cognitive input. Modeling will be part of that, and then skills, practice, and feedback. Those latter two under the key elements will take place when we do the training in a 3-hour session. In the hour and a half, we'll basically be doing it. If we're doing it online through a webinar, we really can't do the feedback and the modeling and the facilitation of those sessions. But we are accepting invitations to conduct those kinds of training programs. I think we already have one scheduled, Rolla, Missouri, early next year. And then we've already had some conversations with folks at MU on the campus of, at the Frail Elderly Conference that will take place next August in Missouri. And then Karin is working on a number of programs that we'll be offering in Kansas. We just ask you to watch for information from us as we do this. This will actually be 3-hour sessions where that skill, practice, and feedback loop, that modeling actually takes place. So bridging the gap and between the evidence and the real world, obviously, are the processes that we'll be using, the checklist that we'll be using, assuring adherence to the process, the key processes that will be identified, achieving higher levels of baseline performance. This is actually helping improve the skills of those of you, the providers, that want to go through this and participate in it, and then ensuring that the completion of the necessary tasks are done during complex, stressful situations, so that we're not running from the problem at the time that the discussions heat up or the family members come in and begin to kind of undo what it is that we've tried to do. So giving me the words is really what we're hoping to be able to do, being able to help you feel unstuck as opposed to stuck, and reminding you to cover the elements of the conversation more systematically. That's another tool that we're hoping to be able to do, so that it becomes more second nature to you. You're practicing and facilitating on those skill sets, that it is focused more on the guide for the conversation and not the completion of the form. In fact, when we were working with Steve Zweig at MU, he was very clear with us that if you guys want to come over here and do another training program about filling out a form, I'm done with it. We're not doing it. But if you want to come and talk to clinicians about how to do a better job of helping guide families through these very difficult conversations, bring it on. So that's kind of the way this conversation and training will unfold. and giving a structure to the conversation that triggers meaningful responses from the patient. So it's not just, I got a job to do here, I got a check box, I got to get done, but actually basically kind of eliciting some of those sacred notions and intimate sharings that need to occur between families and patients, so that we're better equipped to make sure that we're honoring those preferences and values along the way. The outcomes to that, we're not necessarily saying that decision has to be made, but that the conversation will be documented. So it needs to be in a place where it's easily accessed by other providers, and it needs to be documented in a way that conveys the person's current goals and wishes. Those current goals and wishes obviously may subtly change over time, but we need to understand them in a way that makes sense and make sure that the documentation is done. And I think you're all aware now that you can have these conversations, the early ones as well as the later ones, and bill Medicare for those services. And there's a set of providers that can do that: physicians, nurse practitioners, physician assistants, and clinical nurse specialists can all bill for those services. It doesn't mean that the services have to be limited to that group. You can facilitate this early discussion with social workers and other team members, chaplains, in long-term care settings, sometimes even in community-based outpatient settings. But the actual billing codes to be acceptable must be done by one of the qualified healthcare professionals in order for you to be able to do that. If you need information on that, we also have that information that we can make available to you about how that happens. But I think most of you should probably be aware that the advanced care planning billing codes are in place already. We also note that in this conversation, as these conversations occur, that patients may want to complete an advance directive. And if so, that would be a great outcome. It's not necessary. We're also hoping that they would appoint a durable power of attorney for healthcare. That is, I think, again, it doesn't have to happen, but our hope is that at least there's enough discussion to get us on our way to make sure that that does occur. And those are actually outcomes that we're hoping to be able to do. And then obviously, for those that fit the question about would you be surprised if the patient died, that the patient may want to have preferences translated into an actual provider order set, and that's where the TPOP tool will come about. So as we go further into this discussion, these trainings will hopefully be able to go specifically into what do I say, how do I react, what's my next question, how do I keep the patient engaged, when do I back off, when do I allow them to kind of be just to sit with it a while because it's too new, it's too hard for us to continue in this conversation, but to be able to feel good about that and then just make sure that we loop back later to make sure that we're able to do a good job. So developing the methods to identify serious illness in a patient, and where the surprise question is no, I think we talked about that already. Developing the workflows will be something that we spend a little bit more time on in future training programs, and the goal of developing documentation tools that make the outcomes of the conversations as obvious as allergies. And that's one of the things Susan was talking about earlier. It's very, very important to document this. We really don't have a set of tools that we've relied on in the past, but we want to get to the point where you guys are as equipped and able to have these conversations as you are with families when they identify to you any allergic reactions they have to medicines, that it should be hopefully it may not be as quick as that conversation, but that you have the same confidence and same skill sets to be able to do that. And then for patients who wish their preferences for treatment translated into those orders, that we actually are able to execute those, make sure that they get issued, and then transfer with the patient back to whatever place of setting that they have that they would like to make sure that that's shared. So it's a great conversation. It happened, but where are we going with all of this? So this kind of circular discussion means this is not a one-off conversation. These have to recur over time as the patient goes from one setting to another, as an episode, a new episode occurs. And so that constant cycle has to occur over and over again. It doesn't mean they have to name a new agent. It doesn't mean that they necessarily even have to change their healthcare directive. But in many cases, if they complete any kind of a physician order set, we need to be aware that that too is not a one and out conversation, that it needs to be revisited depending upon where the patient is when they change locations and when the disease progression changes or a new diagnosis is made, or we end up in the hospital or back into skilled care. Susan, do you have anything you want to add on that? You're on mute.
I'm sorry, I just wanted to interject here. In the previous slide, we talked about workflows, and one of the challenges for every organization is once we start down this road, how do things happen? Where is it documented? When they come in with, if they come in with a TPOP form, where does that go? So there are who asked the question. So there are a lot of work processes that have to be attended to before you really jump full blown into this whole process. And that's what we're hopefully can help you with as we move through this over the next few months.
Okay, so serious illness care planning is most effective when the outcomes obviously go from one setting to another. We know that's the biggest challenge that most of us face, is we have a good conversation with them in the long-term care setting, and then we have an emergent episode, they end up in the hospital, and everything, you know, goes south or whatever, and they end up in the ICU, and we've got them on a vent, and everybody's scratching their heads saying, how did this happen? Or we have that episode occur in the hospital and didn't have anything planned, but then we send them home and say, okay, everybody's cool with what we're going to do in terms of the next episode and how we want to handle it, and we want to make sure that when they come back, they don't end up in the ICU again, but we go to med surg, or we go to the ER, but we don't end up in the ICU. How do we make sure that happens? And so we've got to actually set ourselves to the task of building kind of a different infrastructure and making sure that what we're focusing on first are the goals and the preferences of the patients, making sure that they're known, that we're reviewing them and respecting them in transitions wherever those occur, and that we're revisiting them over and over again. And the way for us to do that is to build those competencies and capacities, that we're asking the right questions, we're eliciting the right comments, and that we're documenting those in a way that makes sense within our own workflows and our own work environments. So that's kind of our challenge. We're going to spend the next part of this training program going into a little bit more on terms of some of the legal and ethical dimensions of how to do that, making sure that we're not leading patients down a path that they just necessarily are reluctant to go, or going too fast. So that will be in the second half of today's remarks, but we're going to take now a quick 10-minute break or so,